My objectives for this lecture is to provide a practical approach and evaluation of cardiomyopathies based on how they present for cardiac imaging, and based on the pattern of delayed enhancement, narrow down the cause and putting that in conjunction with the various morphologic findings and function, which we may be evaluated by echocardiography or by CT or MR. In general, cardiomyopathies comprise a large group of myocardial disease characterized by abnormal myocardial function. Traditionally, it's categorized into three groups of dilated, restrictive, and hypertrophic cardiomyopathy. WHO classification has added a few more classes and regrouped them. In general, regardless of the cause, when the clinician's suspicion exists, the first step usually is echocardiography, where the function is assessed and there's abnormal contractility or relaxation. By echo, CT, or MR, the morphology of the ventricles and atria can be seen. On MR, you can see further signal abnormalities, also seen maybe with CT, depending on what it is. And you can also confirm the other findings on the morphology or secondary signs of heart failure, usually with CT, where a larger range is included, where you can see both right and left ventricle failure based on what type of disease it is. When the patient's presented to us to the cardiac service, usually ischemic cardiomyopathy has already been excluded, either by coronary cath, which is mild or normal, and there's no anomalies, and a stress test of some kind has been done, either by scintigraphy, stress echocardiography, or just an exercise stress test, which is either negative for ischemia or infarct, or it's equivocal. So the role of cardiac CT and MR initially is to confirm both the echocardiographic findings, and by using intravenous contrast, gadolinium, and looking for late hyperenhancement, and we're putting a specific pattern to exclude ischemic cardiomyopathy, either infarct or ischemia, if a pharmacologic stress perfusion study is also done in conjunction with a delayed enhancement, and by identifying the pattern of late gadolinium enhancement to suggest a specific cardiomyopathy. When I have cases like these coming to me, I try to put everything together, the clinical presentation, what came from the workup, morphology and function, and the pattern of late gadolinium hyperenhancement. Before I launch into cardiomyopathies of non-ischemic causes, I have to first talk about what the pattern of ischemic cardiomyopathy is going to be so that we can contrast that with everything I'm going to say afterwards. In infarct, the delayed enhancement matches the area of wall motion abnormality. In those cine images, you can see that's the septum, the apex, the anterior wall, and the left anterior descending distribution. In that same area, you're going to see either subendocardial or transmural delayed enhancement. Delayed enhancement means fibrosis and infarct. If this is just ischemia without infarct, we're not going to see the delayed enhancement. And that has to be identified by some sort of stress perfusion study. Then the next thing is, if there is delayed enhancement non-ischemic cardiomyopathy, you're going to see the delayed enhancement that not following a vascular pattern or following a pattern that doesn't match. So it's not going to be the typical subendocardial transmural that we expect to see with ischemic cardiomyopathy. And sometimes you just see no delayed enhancement. I'm going to present the cardiomyopathies in 5 main clinical scenarios in terms of how they come to us on service. So the first scenario is patient with chronic congestive heart failure, abnormal systolic function, and the myocardium is thin. On chest radiograph, you can see global cardiomegaly. On cine MR, you can see the ventricles are dilated, they're not functioning well, and based on severity, you can have atrial enlargement because of the mitral regurgitation. There was no late gadolinium enhancement. This is a case of idiopathic cardiomyopathy. In idiopathic cardiomyopathy, you could have either no delayed enhancement or like this image towards the right, you can see mid-myocardial linear delayed enhancement because of the fibrosis that they undergo. In these cases, the myocardium is never thickened. The cause for non-ischemic dilated cardiomyopathy is usually not identified, 50% are idiopathic, and alcohol is the most common secondary cause. Three-vessel coronary artery disease has to be excluded because from a functional point of view, that it mimics that. However, with this sort of thing, you could, the coronary cath and the scintigraphic studies are always going to be abnormal. The next scenario is a young person with arrhythmias and focal systolic dysfunction. Based on this history and presentation, the considerations are non-compaction, arrhythmogenic right ventricular cardiomyopathy, and cardiac sarcoidosis. Any of these cases are treated with defibrillator. I'm going to only cover one of these diseases. This is a young patient with arrhythmia and focal systolic dysfunction. You can see the ventricle is very hypokinetic in a global fashion. There is overtrabeculation of the myocardium of the lateral wall and the apex, and mostly in the mid to distal myocardium. I'm not showing you the late gadolinium enhancement images, but that was normal. This pattern that I'm showing you is non-compaction. This is caused by failure of compaction of the endocardium during the 5th to 8th week of embryogenesis. What's seen is a lacy myocardium where the depth of the trabeculae is twice of that of the thickness of the remaining myocardium deep to that. This is more common in children, and it could coexist in complex congenital heart diseases. For instance, in the images towards the right, this is a patient with tricuspid atresia with levo transposition of the great arteries. You can see despite the fact that the left ventricle is doing all the work and it should be very diffusely hypertrophied, in that apex and anterior wall, it's very trabeculated and the myocardium is thinned out. For instance, here it should have been thick too, and it's thinned out. So you have to have the trabeculae and the thinning at the cost of the myocardium where you can see the areas that are not involved. Mimic of this is any long-standing ischemic or non-ischemic dilated cardiomyopathy. Eventually, with remodeling, you can see this kind of lacy appearance. So we can't use that 2-to-1 ratio for everybody to say, okay, then we saw it and it's non-compaction. The third scenario is somebody who has acute chest pain, elevated troponins, but normal coronary cath and stress tests. Based on this clinical presentation, the two things I think about are viral myocarditis and Takotsubo. Both of them are usually reversible with good outcome. This is a 25-year-old man awakened by severe substernal pain. He had no past medical history of anything. His troponins were elevated. He got a workup for P and aortic dissection, which was negative. EKG, echo, and cath were all normal. When we look at the functional images here, you can see that this lateral wall has a high signal in the subepicardial distribution. This is without contrast. So if I have high signal on the SSFP images, that suggests that there's edema there. You can see that again here in the lateral basal wall, which looks a little thickened. And on the delayed contrast enhanced images, you can see there's subepicardial delayed enhancement. This is viral myocarditis. The tissue characteristics could be very helpful in the acute phase if edema is seen. These people could have pericardial effusion, sometimes with pericardial enhancement. The CineMR is usually focal hypokinesis, but like for instance in this case, the hypokinesis was subtle. It depends on how much of the myocardium is involved to appreciate that hypokinesis. The most typical pattern of delayed enhancement is subepicardial, as I showed you here, but sometimes it can be transmural, it could be mesocardial or nodular. Serology for the viral antibodies could confirm this diagnosis with any of these viruses being the cause. A history of a recent cold is very helpful. It is most common in children and young adults, and it's usually reversible. So these patients get followed up with echo and MR. And in MR, what we tend to see is reversal or decreased size of that delayed gadolinium enhancement. However, there are cases that can progress to severe dilated cardiomyopathy. The image towards the left shows this mixed epicardial and transmural and some areas of mesocardial delayed enhancement in a child. This one towards the right shows diffuse delayed enhancement in somebody who had a year ago had a viral infection, myocarditis. It progressed and developed diffuse fibrosis, and at the end presented as a dilated cardiomyopathy. Now, subepicardial late gadolinium enhancement is not only seen in viral myocarditis, it's seen in other causes too. For instance, polymyositis, you can see it here. Sarcoidosis may present as a subepicardial pattern, and muscular dystrophy, again, goes from outward in. This pattern of outward in is not a pattern that you would see with infarcts, even if this could be in the pattern in the vascular distribution of the circumflex artery. You should never see outer to in with infarcts or ischemic cardiomyopathy. In these kind of cases, the history is always known, so that's very helpful. The next scenario is a patient who's 42-year-old. She had acute chest pain. Her EKG was suspicious for ischemia. Troponins were elevated. However, the workup for PE and aortic dissection was negative, and the echocardiography showed depressed function. The coronary cath was normal. So when I approach something like this, the thought I would have is, well, I see somebody who has diffuse hypokinesis of most of all walls of the apex and mid-ventricle, with only the basilar walls functioning here. So anytime, when this patient goes in systole, you can see the base thickens and it becomes narrow, and in the remainder kind of balloons out because it's just basically doing nothing. And there's no correlating delayed or late gadolinium enhancement. This is a case of Takotsubo. So how do I tell these two apart if this is somebody who has bad ischemic cardiomyopathy but not infarct versus Takotsubo? This is where scintigraphy is very helpful. Scintigraphy is needed to with the pharmacological perfusion to exclude ischemia. And if that's normal, then you have to think about something like Takotsubo. This is broken heart syndrome. It's usually reversible. The cause of this is because of the sudden catecholamine release that happens with severe stress. It's usually a middle-aged woman, and what's seen is exactly what I described, that ballooning of the left ventricle in systole. So because of that, it's a shape that's very similar to an octopus pot, and that's what Takotsubo means in, I believe, Japanese, an octopus pot, where this is the neck of it, and this is the rounded shape of it. And there's no late gadolinium enhancement with this. The next scenario is somebody who has chronic congestive heart failure. On echo, they see both systolic and diastolic dysfunction. Anytime you have diastolic dysfunction, you have to exclude the known causes that usually occur, like diabetes, hypertension. With this kind of history, things I will be thinking about is a restrictive and infiltrative cardiomyopathy when somebody has global hypokinesis, but the myocardium is not thinned out. From a clinical and echocardiographic point of view, what they usually want to exclude when they have this pattern is constricted pericarditis, and we're very helpful in excluding that. Sometimes for infiltrative cardiomyopathy, an endomyocardial biopsy may be needed for final diagnosis. Restrictive cardiomyopathies, regardless of cause, based on how severe it is, could have similar appearance on morphology where the ventricles could be small, and because of the biventricular failure, the atria balloon out. So the ventricle takes on this the whole heart takes on this bullet shape appearance, similar to what's described in constricted pericarditis. Because of the biventricular failure, we'll see signs of failure, meaning pleural effusion, pericardial effusion. Here's a nutmeg liver and dilated IVC, and the patient could have lower extremity edema as well. On seeing images, the function will be abnormal, and based on the cause, a late gadolinium enhancement could have various patterns, which we'll cover. We said the main differential diagnosis, constrictive pericarditis. The image towards the left is somebody with a restrictive cardiomyopathy, and this one towards the right is somebody who has a constrictive pericarditis. Both have ballooned atria. However, with constrictive pericarditis, you should always see thickened pericardium, which may or may not be calcified. It's typically close to the AV groove, and because of that, the ventricles become elongated. On MR, if real-time imaging is done with sudden inspiration, we can also demonstrate the interventricular dependence, which also is a find that would be seen with constrictive pericarditis. In this clinical scenario, you have a 68-year-old man with congestive heart failure, which was chronic. his workup was negative for ischemic cardiomyopathy. You can see here that the myocardium is not thinned out, but on delayed enhancement, there's a subendocardial delayed enhancement. It's very confluent. It's involving the anterior, lateral, and inferior walls. And in areas it's almost transmural. When you look at the lumen and myocardium, there's very difficulty to separate the myocardium from lumen, and the lumen looks very low in contrast. When we see that in conjunction with the subendocardial delayed enhancement, the thought that we have is amyloidosis. So in amyloidosis, the ventricles are either thickened or normal. In this case, you can see the right ventricle is significantly thickened because of deposition there. There is diffuse hypokinesis along with it. Late gadolinium enhancement pattern is subendocardial, but it could be, like I showed you, transmural or mesocardial. And you can see that the opacification of the lumen is depressed. It could be circumferential, and it's very difficult to perform the inversion time because of this fact that the contrast gets absorbed by the amyloid deposition elsewhere or generally in the body, and because of that, it looks like somebody whose gadolinium injection has infiltrated. There's not a lot of gadolinium on board. However, despite that, here you can see the subendocardial delayed enhancement, which was circumferential. There was also some delayed enhancement of the right ventricle. That's usually seen if somebody has right ventricular thickening as well. Here's a different patient, which I showed earlier. You can see that there's transmural delayed enhancement, and it's involving almost all of the walls of that left ventricle. So what's a differential of somebody who has circumferential subendocardial delayed enhancement? Again, we have to exclude 3-vessel coronary artery disease with infarcts. Usually that's not symmetric. Amyloidosis could be circumferential or non-circumferential, but the additional findings of porous opacification of the lumen is very helpful in that. Fabry's disease is rare in kids, and in the post-cardiac transplant cardiomyopathy, that is, they have a specific history for that. Here's an example of eosinophilic cardiomyopathy where 2 different patients, here you can see subendocardial delayed enhancement, and this patient, the subendocardial enhancement is here adjacent to intraluminal thrombus. The presence of thrombus is a very strong indicator of eosinophilic cardiomyopathy. It usually involves the apex and mid-myocardium, spares the bases. And if we check the eosinophil count in the blood, or a tissue biopsy is done, you can see eosinophilia in the tissue as well. And the features, if seen with this pattern, is very typical, and we can be very helpful in making that diagnosis. The second case here is a patient who has nodular and areas and confluent areas of delayed enhancement and a non-vascular pattern. Here it's mesocardial, here it's transmural, mainly involving the base of the heart. There's associated hypokinesis of the areas that are having delayed enhancement. This is a patient with cardiac sarcoid. Cardiac sarcoid, you see, I mentioned in different areas because it does have different patterns. It could be subepicardial, like I showed earlier, mesocardial, transmural. It can be reversible with steroid treatment, so follow-up can show reversal of a delayed enhancement. Like I showed in that example, the left ventricular base is the most common. Here you can see that we have the base, transmural, and mesocardial, but the septum could also be involved. This is a different patient here. We can see that it's nodular. Every case that we've had of cardiac sarcoid in our clinical practice, the patient has had pulmonary sarcoid. So if we don't have pulmonary manifestations, we usually do not call it. If they biopsy it, they may get an answer, but the problem is that this is a patchy involvement of the ventricle, so it's very important that they biopsy the correct location. So it may have a false negative with biopsies. I'm putting in a slide on end-stage cardiac sarcoid because that's different. It's a different pattern. There's 2 different ways that cardiac sarcoid can go into the end stage. It could go on to dilated cardiomyopathy, like I initially showed, with mesocardial delayed enhancement, or it can present with somebody who has pulmonary fibrosis and right ventricular hypertrophy. The ventricle is thickened, the heart is turned, as we see with anybody with pulmonary hypertension, where the ventricular wall attaches to the septum. Because of that chronic strain, there's some fibrosis, and you can see this triangular area of delayed enhancement both superiorly and inferiorly. This is seen with sarcoid, but it's also seen in anyone who has severe pulmonary hypertension because they share that same mechanism. The last scenario is a patient who's young, has arrhythmias, they have preserved systolic function, but the diastolic function may be decreased. However, the myocardium is definitely thickened. If it's a concentric thickening, things that have to be excluded is someone who's an athlete, has hypertension, any kind of outflow stenosis through the left ventricle, be it from a subaortic membrane, valve, or supravalvular stenosis. With this kind of history, you consider hypertrophic cardiomyopathy. There's usually a familial distribution because it's an autosomal dominant disease with variable penetrance. It presents in adolescence and young adulthood, even though it's autosomal dominant. In this clinical scenario, you can see this patient has thickening of the anterior and septal wall. It's asymmetric. That favors somebody who has a hypertrophic cardiomyopathy. The measurement of that thickening has to always be done at end diastole in the two-chamber short axis view. Anything that's more than 11 to 12 millimeters is going to be abnormal. We use 12 for somebody who's an athlete, where they can be higher than most other people. During systole, the lumen can get very narrowed or completely obliterated. So because of the end systolic volume is so low, the ejection fraction that gets calculated is usually pretty high, even though the ventricles do have an element of diastolic dysfunction and poor relaxation. If the delayed enhancement is seen, it's going to be mid-myocardial and mesocardial because there's an association. These people do have abnormal coronary arteries. They do get stenosis because of that, and therefore they get small infarctions and fibrosis within the areas of thickened myocardium. In the variant where there's the apical variant, usually where the delayed enhancement is going to be in the apex, and these can go on and develop apical aneurysms, which then need to be followed because of they could also get thrombus and then embolize. Regardless of the pattern of hypertrophic cardiomyopathies, people can develop arrhythmias and ventricular fibrillation. It's because two reasons, because of that fibrosis that I described with the small infarcts, and also because the myocardial cells have a very irregular lining, which affects the conduction system as well. Because of the ventricular fibrillation, they can develop sudden deaths. In apical variant, or the Asian variant, there's a typical EKG pattern where there's large peak T waves, and if that may come as a history, and if you see that, then you have to be thinking of excluding the apical variant of hypertrophic cardiomyopathy. The right ventricle could also be involved. In this example here, with this person has a septal variant, you can see there's right ventricular thickening as well. Here's 4 different examples showing the 4 different main variants. Here's the apical variant. It could create this elongated heart, and on LV grams, this creates a spade-shaped heart because of the lumen looks like a spade. Diffuse hypertrophic cardiomyopathy could we have to exclude hypertension or valvular stenosis. And mid-ventricular hypertrophic cardiomyopathy is pretty rare. You can see here in systole, the lumen completely gets obliterated, and the apex starts ballooning out because the blood flow goes in both directions. Systolic anterior motion of the septal leaflet is something that's described with hypertrophic cardiomyopathy. It's seen with a septal variant, and the septal variant, therefore, is obstructive. Because of the left ventricular outflow narrowing that's seen here, because of that thickened myocardium, there is increased velocity of flow that, based on the Venturi effect, causes a negative pressure, which pulls the anterior leaflet of the mitral valve towards the septum during mid-systole. So looking at the cine image here, during systole, the mitral valve is supposed to be closed, but you can see the entire mitral apparatus is pulled towards the septum, and because of that, there's going to be mid to end systole regurg. Here's the regurg there, and this leaflet can hit the septum, which is what the SAM is, and that accentuates that dephasing jet that's there. What's a mimic of SAM is the subaortic membrane. For instance, in this patient here, you can see there's a ridge of tissue here that also pulls the septal leaflet inwards, and it could be independent of hypertrophic cardiomyopathy or coexist with it. If it coexists, then there's a poorer outcome. So radiologists have a major role in identifying ischemic cardiomyopathy. The diagnosis of non-ischemic infiltrate cardiomyopathy can be made by imaging, and we can be very helpful in assessing for complications of hypertrophic cardiomyopathy or differentiating restrictive cardiomyopathy from constrictive pericarditis. This is a table of the different various delayed enhancement patterns.